this needs a bit of a preamble because, of course, all countries are different in terms of healthcare organization. And in 2007, Holland passed a healthcare bill that did away with the public-private divide that had been present in the Netherlands for the better part of 100 years. And along with that, there was a long preparation, like 30 years of discussion where healthcare should go, who's responsible, who is actually the driver of changes in healthcare reform. And in good Dutch poldering, which is not a transmittable disease, but a form of bringing people together, actually there was, in an interdependent way, the government, the insurance companies, the patient representation groups, the hospital groups, and the professional bodies were interdependently linked by ways of feedback loops, by ways of annual negotiation of contracts between insurance companies and hospitals, by quality and volume outcome norms for the professional bodies. And this then set, I think, the scene for the colorectal audit, and I'll explain later the Dutch Institute for Clinical Auditing. And it's been a runaway success, which I think is to do with that long period of discussing where that healthcare in the Netherlands should go, and certainly in terms of cost containment. Now, obviously, this is me on the Italian beach that I was at yesterday, flying in this morning. So forgive me if not all is as clear as it should be. Anyway, I became interested in audit in the late 90s, and this was actually at the same time that the Royal College in the Netherlands was interested in the aviation industry in terms of leadership, in how you provide leadership within a very well-trained team. I was more interested in risk management and in how do you audit outcome data, but then combine that with risk management and risk certification. So this is, you've seen this in the previous speaker, and to do this well you need reliable data, and that's where the crux of the heart of the matter is. Now we all know that things can go horribly wrong, or as they would say, bad things happen. Do you get it? You haven't been on a plane. I have. Anyway, to have a functional operative risk management structure will allow you, when things go horribly wrong, like with the Columbia, will allow you to let geniuses like Richard Feynman come up with what actually went wrong in this very complex matter, which was only a rubber O-ring of $2 worth that didn't expand enough at the freezing point, and that was not when that space shuttle should have been launched, but it didn't expand enough. So that's when the rocket booster exploded. He wasn't the only one to understand that hospitals are not the safest place to be in when you have a disease. And this is actually Florence Nightingale noticing that you probably shouldn't be in a hospital at that point in time. Now, a caveat is that with all the data that we have, that we all try to find patterns, and I wholeheartedly agree with Ian Stewart that numerology is the easiest and consequently the most dangerous method for finding patterns. It's easy because anybody with a spreadsheet can do it, and dangerous for the same reason. Now, I had a spreadsheet in 2003, I think, and this, when I got hold of the data of colorectal surgery in the Netherlands, a complete data set of all resections performed from 1994 to 1999, approximately 70,000 patients. And then we didn't look at it in terms of a normal multivariate regression analysis, but a more sophisticated multi-level hierarchical analysis, and found that 7% of Dutch hospitals were outliers in terms of how they contributed to the effect, meaning how they were different in terms of their performance. Now, there weren't enough data, I think, in that data set to explain why it is that they were outliers. And this then formed, or was the nidus for the Dutch Working Party for Colorectal Surgery. And we started to think about audit and what the use of audit would be. And again, this has been shown in previous slides, so I won't dwell on it. But in 2006 or 7, that Dutch surgical colorectal workshop, Working Party for Colorectal Surgery, was formed. And what we did was we convinced people to contribute data to a surgical audit. This was a surgeon-driven national experience, and we had our first audit year in 2009. But I think the flipping point was when in 2012 the Health Inspectorate accepted our Dutch colorectal data as being integral part to what was already compulsory for hospitals in terms of other KPIs they had to deliver. And then in 2014, so in the space of 5 years, we had participation data entry by 80 hospitals, and that excluded no hospital in the Netherlands. So all colorectal surgery performed for cancer was in that database. Quite a powerful tool. And this then formed the beginning of the Dutch Institute for Clinical Auditing, which is the DICA. Now, the DICA partners with many, I would say with all interested and involved parties, but mainly with the political parties, the government, the hospital organizations, patient representation groups, professional bodies, etc. I know this is too busy, but it shows you on the left upper hand side the explosion, if you like, of data in the DICA. So in 2009, that's the first registry, which is the Dutch Surgical Colorectal Audit. There's about 7,000 patients. And in 2016, there's 20 registries, and there's 520,000 patients with full data in the registry. Now, it's not all cancer. There's lung cancer, there's breast cancer, there's hepatobiliary, colorectal, but there's also cerebrovascular accidents, there's hip fractures, etc. So in the lower left corner, you can see that the first one, the orange bulb in 2009, is the Dutch Surgical Audit, and then in 2016 on the right-hand side, there's 20 registries. And it's growing, so every year there's a couple of more that enter. And on the right-hand side of the slide, you can see, it's barely readable, but if you, the bottom one is the NBCA, that's the breast cancer audit. And there's 80 hospitals in the Netherlands that perform breast cancer surgery. Same, likewise, you can see DSCA, Dutch Surgical Colorectal Audit, again, 80 hospitals that perform colorectal audits. So it's a much simpler situation than in Australia. It's become very successful, and this is the third annual conference that the Dutch Institute for Clinical Audit has organized. It's a 2-day conference, and it encompasses all the registries. Now, the Dutch Surgical Colorectal Audit has chosen not to be too parsimonious. We were thinking we want to know why there are differences. If there are differences, we want to know why, and we don't want to go back and then have to revisit the patient. So we've chosen to go for quite a large set of data, which puts a lot of strain on the surgeons, on the hospitals, because it's surgeon-driven. It's surgeon entry data for the colorectal audit, in combination with the hospitals, sometimes with data managers. So if you look at the process and the structure of the Dutch colorectal audit, these are data showing you 2013 on the left-hand side and then 2016 on the right-hand side, numbers of patients. There's about 11,000 resections annually in the Netherlands. And this boils down to, on an average, 140 colorectal resections per institute, which is far above the minimum, if you like, volume outcome, if you like, norm. Certainly, if you look at what's happened in America. Then there's a number of things you can do, and there's a granularity of data that allows you, for example, to say, so how are we doing in terms of first, so time to diagnosis and then time to first treatment. For example, in colon, fairly stable. But in rectum, you can see that we are probably going and steering away from neoadjuvant treatment. As you know, in the Netherlands, we've been very keen on radiotherapy, neoadjuvant radiotherapy, and then chemoradiotherapy for rectal cancer. But actually, there's a tipping point here, because we're now going slowly but surely into the direction of less neoadjuvant treatment. And these are just examples of what you get out of this database. So it's much. So, for example, the elective to acute ratio, I think, is very much to do with what is actually happening with that colorectal audit, because it flips the number of hospitals and the number of surgeons doing colorectal surgery into more specialized teams. And hence, probably the elective to acute ratio is changing. So if you look at outcome parameters, for example, the R1 resection, when there's a pre-op diagnosis of a T4 colon cancer, is a spectacular, I think, improvement. Although it's only 7%, but it's a 10% relative improvement in terms of how many, this of course is wrong. It's the R0 resection, of course, but there's 93.3 R0 resection in CT4 colon cancer. Likewise, for rectum, there's an improvement in our R0 resection rate in our CT1 to 3 rectum cancers. And although it's 5.2 to 3.6, I mean, this is a 30% improvement. I think it's very impressive. Then abdominal perineal, again, a function of, I think, specialization, teamwork, and team approach. Again, a 30% reduction in abdominal perineal resections. And it's not that we've done this at the cost of more complications, because actually the complications in both colon surgery and rectum surgery have diminished over those 4 or 5 years of complete colorectal audit. 30-day mortality rates have come down, again, 30% reduction rate. And a failure to rescue, which was, in the beginning of the audit, was actually a problem, because return to theatre is associated with rescue and not failure to rescue. But the return to theatre was a negative KPI in the first years of the audit, whereas finally when we understood that perhaps failure to rescue is far more important than return to theatre, it was replaced by failure to rescue. And failure to rescue, you should look at that as at what stage, for example, in a leak after an anastomosis, have you brought the patient back to the theatre? And failure to rescue would then be like 7 or 8 or 9 days, whereas the average would be 3-4 days. So that's a KPI for, I think, quality of care. Now, is this then due to different ways of treating patients? So this shows you that over the past 4 or 5 years, the minimal invasive approach in the Netherlands to colorectal cancer has grown to approximately 90%. So 90% of all patients are, in principle, managed minimally invasive. And hence, the open, of course, has dropped to about 10%. And it hasn't sort of led, the lower 2 lines are the conversion rate. And so we've done more minimal invasive surgery, and we've got less conversion. So we're getting better at our surgery, even in a short period of 4 to 5 years. Now, this is not an explanation, I think. It can also be just the Hawthorne effect. Is if you look at someone, he'll perform or she will perform better, certainly for a certain period. But I think the impressive results are not just Hawthorne effect. I think they're actually related to how the colorectal, if like surgery in the Netherlands, has changed over a very, very short period of probably 5 to 10 years. Now, this is unreadable, but this is just to give you a slide that shows you the granularity of the detail of the data. This is looking at time to MDT and time to first treatment, but then the difference between, if you like, teaching hospitals and academic hospitals. Someone alluded to that it's a powerful resource for research, and this is just the annual research requests for that Dutch Institute for Clinical Audit. There's about 200 requests for research. Now, I'm not going to say that this is the solution, because for every complex problem there's a simple solution, and it's invariably wrong. So maybe we should cherry pick and see what the combination of both systems and both ways of looking at audit could bring us. Thank you.